Well, here we are again in midterm one, and what we want to do is today we want to talk a little about some pathological terms, as well as some conditions, and maybe a few abbreviations at the very end in regards to the respiratory system. It's going to be a little bit complicated, but it's going to rely upon a lot of the words that we've talked about before. So let's go ahead and get started with that. First thing we want to start with are some diagnostic terms, okay? And these are terms that are commonly used in multiple situations around the clinic and stuff like that. So these diagnostic terms are really quite critical to know, okay? First of all, let me give you a first word is auscultation. Okay, and auscultation basically means to listen. So when they use a stethoscope and they're listening to something, they really auscultate. So the process of listening to breath sounds, to heart sounds, and things like that with a stethoscope is called auscultation. Okay, so that's the first word. Second word we have here is palpation. Now, palpation is done. Palpation means to feel and to touch. There's a lot of things you could do in the chest. There's a thing that's called vocal fremness. It's just one of the things. And what happens is what you do is, and you can actually test this on somebody else you know. Now put your hands around their chest. Just grab the chest from the side and have them say like 99 or moon or something like that. And you hear some vibrations that are created by the air that's going through the lungs, okay? And if they have certain pathological conditions like pneumonias or something like that, where there's pus or fluid in the lungs, it changes the feeling of the vibrations that you're actually able to feel. Also, palpation would be to feel like the chest for like rib fractures or areas of tenderness or anything like that. So anytime you actually feel something and use your hands to make an evaluation, that's called palpation. The third word that we have here is percussion. Now, you probably wonder what in the world the doc's doing. They take their fingers, they start to tap and tap and tap and tap. What they're doing is it's just like percussion, like in a drum. The idea is the lungs are going to be filled with air. So when they percuss over that, when they tap, okay, you can do this against a wall. And as you're going along it, when you finally get to a stud, there'll be a dull sound. If you're over areas where there's no stud, it sounds sort of empty behind that. That's because it's air behind that. And that's what they're doing with the lung. They're actually percussing. They're going along the lung fields in areas that might have a tumor or pus or fluid. They won't percuss the same. They'll be very dull, okay, like over a stud in the wall. And over the heart will be actually pretty dull. I can't hear, but I don't know if you could hear the difference of the sound. I could hear it myself. It sounds a little bit different. So over my heart and over my the sternum, it sounds very dull because there's solid material behind there. However, if I go along the lungs, it sounds more resonant or tympanitic. So that's what we see with what's called what they're doing when they actually percuss. A pleural rub. A pleural rub is a situation where we know the pleura is that membrane that lines the inside of the chest and it covers over the lung itself. What happens is sometimes there'll be some inflammation of that pleura, and that pleura, instead of being nice and smooth and slidey, becomes sort of gritty and inflamed and rough. And as a result, what happens is when people take a deep breath, the pleura, the visceral pleura, the parietal pleura will scrape along each other. And some people actually describe this sometimes sounding like taking two pieces of sandpaper and rubbing two pieces of sandpaper together. And that's what we get with a pleural rub. So, and in the area where the inflammation is of the pleura, you'll hear this sandpapery type rub when you listen over the top of it. And that's called a pleural rub. The next thing we have here is called rales. Okay, now this isn't rales down here in this cup. We're going to get down to this. This is actually sputum. But when areas of the lung aren't being used, these little alveoli start to close off. Or sometimes in certain pathological states, these alveoli become filled with a little bit of fluid. So when we breathe, there'll be some crackles. And a lot of times what happens, instead of using the word rales now, rales was the old word. Now a lot of times they just use the word crackles. And basically, some of these crackles almost sound like if you take two pieces of Velcro and you pull two pieces of Velcro apart, that crackling sound that you get is basically what you get with these rales, okay? If you wake up in the morning, the lower portions of your lungs don't aerate as well. In your first couple of breaths, if you listen to it with a stethoscope, you hear these crackles until you take some real deep breaths. Okay, so crackles could be normal, just opening up areas of the lungs that haven't been used for a while, or they could be abnormal if there's a lot of fluid or things like that that are actually causing almost like bubbling occurs inside these little alveoli, and that's called rales. Rhonchus is a little bit different. Rhonchus or a rhonchi Okay, rhoncus would be singular, rhonchi would be plural. These are large, loud bleeding sounds. When people are breathing, or a very abrupt, very gross, um, almost like sounding like sometimes a mooing or a sheep bleeding or something like that when you listen to the lungs. And where the rales are usually involving, the rales or crackles are usually involving small airways in the alveoli. The rhoncus usually means there's a lot of garbage and gunk and debris and fluid and pus and sputum and stuff like that in the larger airways. Okay, so those are called rhonchi. Sputum, that's what we see over here. Okay, now sputum isn't spit. Sputum is a lot of the deeper secretions that you get in your lungs. And again, we talked about the cilia, how the cilia move that stuff up towards that area of the lung or of the bronchi where they come together to the trachea called the carina, where the cough reflex is, and you can cough this stuff up. And this is a lot of foul stuff. Sometimes with people with bronchitis, this sputum will be green or brown or sometimes blood tinged. Sometimes even sort of blackish, okay, because of all the garbage that's in there, okay, and that's called sputum, okay. It's not spit. Spit's the stuff, the saliva from the mouth. Sputum is the deep secretions from the chest, okay. Stridor. Now, stridor occurs when people have difficulty breathing, okay. People with chronic obstructive pulmonary disease or emphysema, chronic bronchitis, they have difficulty at times getting the air in. So when you watch them breathe, they'll be if you look, you'll see this area above the clavicles. It'll sort of sink in on both sides. The sternocleidomastoid muscles in the neck will stick out like a sore thumb, and they usually have to hold on to something. And by holding on to something, it stabilizes the arm and the scapula to allow them to breathe a little bit better. But when they have difficulty breathing, and they demonstrate this physically, they have to use other muscles to breathe. It's called stridor. Okay, so that's what we see with stridor. You'll actually see if somebody has asthma, they have trouble getting air out. And you actually see the stridor because the abdominal muscles are firing to try to push the diaphragm up to get the air out because asthma is more of an air trapping type disease. Okay, which gets me to my next word, which is wheeze. And a wheeze is a situation where there's small little squeaks that we will hear, and it's usually because the airways are partially blocked, either by fluid or they're narrowed down. Those bronchioles with the muscles start to narrow down, and you'll hear somebody with asthma wheeze. What happens at the end of their expiration, they'll you hear that little squeak at the very end, and you'll hear this not just audibly when you listen to them, externally, but also you'll hear this quite prominently when you listen with a stethoscope. What I've actually done is I've actually put a video that should be available to you on media site that talks about rubs, rales, rhonchi, wheezes, and stridor, and normal breath sounds. So you can actually listen to that, and it'll show. I think it was a EMT or EMS or something like that that put this video out, but it actually allows you to hear what they will sound like. So if you're interested in listening to those, that's on there. Okay, so rales, crackles, rhoncus, that bleeding, stridors, and you get some squeaks as well. Wheezes are very small squeaks. Okay, and they could either be with inspiration, would be called inspiratory wheezes, or with breathing out, which would be called expiratory wheezes. Okay, so those are some diagnostic terms important to know. Let's talk about some pathological terms here. The first term we have here is croup. Now, if you're a parent, guess what? You've known croup. Okay, croup is basically laryngeotracheal bronchitis, which means if I look at the larynx, if I look at the trachea and the bronchi that'll come down here, they become inflamed. It's either a bacterial infection or it could be a viral infection. It could be a number of different things. And as a result, when they become inflamed, the airway narrows and they have difficulty moving air. The thing that's very characteristic about croup is once you hear the cough, you never forget it. It sounds like a seal. It's a barking type of a cough that they get with this croup. Okay, in most cases the croup is usually self-limited, lasts a couple days, frequently goes away if it's viral on its own. Within about 3 or 4 days, they usually put them in a cool mist vaporizer and it's fine. However, sometimes the narrowing of the airway becomes so significant that people actually have to be put with an endotracheal tube, something to help them breathe a little bit more. The reason why we see croup in kids and not adults is very, very simple, and you probably wouldn't even think about it. The structures are smaller in kids. So therefore, it takes less swelling of the airway to cause more occlusion. As we get older, our airways get larger, therefore they don't occlude nearly as much. It takes a lot more swelling, so we don't get adults with croup. That's why you see it in kids. Okay, and again, this is what we see with croup. We'll see, in the area of the larynx, the trachea, and down to the bronchi, this would be the normal appearance. But what happens is that lumen, or the opening of the airway, becomes very small, and when that airway gets very small, it becomes very difficult to breathe. Okay, and this really shows. Let me get rid of these. Let me get rid of these scratches so you can actually see what we're talking about. Okay, this is just an X-ray of a kid. Okay, and what you can actually see is if I could draw it right here. Here's the trachea right there. Okay, and you can actually see how the trachea, the airway, sort of like narrows down right there. Okay, that's actually called the steeple sign because it looks like a church steeple, but that's the area, the area of the larynx has gotten so narrowed down that it causes that croupy type cough. I'll get rid of that so you can actually see it. Now you can see it. The darker area is the airway, and you can see right where the arrow is pointing how that airway is becoming narrowed so much. So that's a very, very classic picture of that steeple sign that we frequently see in croup. Again, it's usually self-limiting. It lasts for a few days. It could be bacterial, it could be viral. Cool mist vaporizers in most cases, and most kids do pretty well with it. Most kids probably have it at some point or other because it's from a number of different bugs that will cause it. But that's what croup is. It's that barking cough. Once you hear type of a cough, it sounds like a seal, in the next room, and that's croup. Okay, diphtheria is a little bit different thing. Now, diphtheria we don't see much, and the reason why we don't see diphtheria is because kids frequently get a I don't know, I'm not writing here. Oh, what's what? DPT. DPT vaccination. D stands for diphtheria, then that stands for pertussis, which we'll talk about in a second, and T stands for tetanus. Okay, so most kids are vaccinated against diphtheria, and diphtheria is a bacterial infection of the throat. And what happens was they get a very thick area of pus, mucus, and almost like a membrane in the back of the throat. And the problem is that it's also something that occludes the airway. My dad had a brother. Okay, my dad's been gone a number of years now, but my dad had a brother when they was a kid who died of diphtheria because, again, they didn't have the antibiotics at that time to be able to take care of this. We still will see diphtheria in people who are non-vaccinated, but it's relatively unusual to see diphtheria. But it's a bacterial infection that involves the back of the throat. There's a lot of pus and a lot of membrane that forms back there, which actually occludes the airway. That's diphtheria. Epistaxis, this is epistaxis. Epistaxis is just another word that means a nosebleed. So when people have a nosebleed, it's called epistaxis. Epistaxis, nosebleed. Now, pertussis is a little bit different, okay, from croup. And pertussis is called whooping cough. So when you hear somebody say whooping cough, let me write whooping cough there, whooping cough, whooping cough. Okay, and what happens is pertussis is much more significant in most cases than croup, and kids could get actually quite sick. It's a bacteria that will cause the problem of this pertussis. Again, we usually don't see it because with the pertussis, the whooping cough vaccine that they get, the DPT, although if a kid doesn't have his full course of vaccinations, still may get it. Okay, what happens is the reason why they call it whooping cough is because when they cough, it's called a paroxysmal cough. And what a paroxysmal cough means is it's one cough after another 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 cough after another. They have a series of one cough leading to another cough. Okay, and then they go so long that they actually become anoxic. Their blood oxygen will start to go down, and they start to get shorter, and they can't breathe. And then eventually, what happens is when they stop coughing, it's like this. This is what happens. And this is going to tell you why it's a whooping cough. They go cough, 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 cough. They take that big whoop at the end, and that's why they called it whooping cough. Okay. The problem with whooping cough is where croup went away in a couple of days. Whooping cough will be there sometimes for a month or longer. Okay. They go through different stages of pertussis. And it sometimes lasts quite a long time. The thing about pertussis also is if they do have it, okay, It's highly communicable. And what I mean by communicable is it's highly infectious. You can spread it very easily to other kids who would not be vaccinated. Okay, and that's why that's quite important. In other words, if you know somebody has pertussis and they're in a community where there's kids that aren't vaccinated and they've had exposure, these other kids usually should have some type of antibiotic prophylaxis. It's usually too late to vaccinate them at that time. But what happens is they'll treat the kids with other kids that they've been in contact with an antibiotic, because chances are they would otherwise get pertussis. And the thing about it is people are infectious with the pertussis before they actually show symptoms. Okay, so that's a big thing that has to be thought of. Okay, so that's called pertussis. Asthma. Asthma is really common. Both of my boys have had some level of asthma. Asthma is usually caused by allergy. Okay, somebody has an allergy, and the allergy triggers this asthma episode. Okay, however, we're finding a lot more people now that the asthma is triggered by things like a cold. You're out in the cold, and the cold may trigger it. Exercise. I know I used to be the team doc for Ignatius for their hockey team, and on the back boards, I was always on the bench with them during the games, and on the back boards we'd have like 7 or 8 inhalers for kids to use during the game should they have some shortness of breath during the game because of the cold as well as exercise induced asthma. And what really happens, I'm going to get rid of my picture here for a minute. But what really happens is, again, the smaller airways are lined with smooth muscle. For some reason, whether it be allergy, whether it be cold, or whether it be exercise, it causes those smooth muscles to constrict. It makes the opening of the airway much smaller, as well as it causes an inflammation that causes mucus that develops inside there. So all of a sudden now to try, and you got to remember that that's happening up in here, that's happening down here, and this is where the alveoli would be down in here, below this area here. So what happens is I can't get air through that airway, through that smaller airway, very easy. The problem is this the fluid. Okay, if you come down that little airway in this little alveolus here, we have fluid here that comes down here. Air comes down the bronchiole, and it usually allows this little plug of mucus allows the air to get in. But when the air tries to get out, it sort of like puts a stopper in a bottle, and they can't get the air out. A lot of times when we have kids with asthma or adults with asthma, what happens when people have asthma, what happens when you look at their lungs on a chest x-ray, they look like they're full of air. But you know why? Because they are. It's called an air trapping type of a problem. Some people will outgrow asthma over a period of time. They sort of they sort of grow out of it. Okay. I know that both of my boys, my older son, had a lot of episodes when he was very small, but he got older and it got better. Okay. My younger son still has some problems in regards to cat dander. Cats. Anyway, that's asthma. And again, a lot of things bring it on. Allergy, some type of an allergic response, a cold, exercise, things like that. And again, with my son with the cat dander, the skin stuff that are floating in the air from people with cats, and certain types of pollen and stuff like that may cause it. So anyway, that's asthma. Bronchiectasis. Okay, bronchiectasis. Ectasis means a dilation, and this is what really happens in bronchiectasis. When people have chronic infections in their lungs, like bronchitis and stuff like that, what happens is the wall of the airway stretches out, okay? But becomes almost non-functional, because what happens is it also causes the whole wall becomes damaged. But what happens is the cells then produce a lot more mucus, and that creates a very small opening through which the air could go, okay? And we'll see this a lot of times in people with chronic bronchitis and other things like that. We actually see sometimes this happens in both larger airways as well as some of the smaller airways. In fact, a lot of times we'll see it in evidence, I'll show you an x-ray, in the larger airways. We actually see the edges of the airway as we look at a chest x-ray, okay? So you can see here in the larger airways, much more than the smaller airways. It's the larger airways that are usually involved with this bronchiectasis. Bronchiole, or bronchi, and ectasis means dilation, but then that area that's all pouched out starts to fill with all kinds of mucus and stuff like that. So basically it's a lot of garbage that sits inside there. Sort of like you know, a storage area for a lot of stuff that you don't want. You throw it in there. Well, that's what happens with bronchiectasis, okay? And when I actually look at a chest x-ray, if you look between the two arrows right there, okay? So let's look at, here's an arrow right here. Here's an arrow right here. See those two white lines that go in there? Or sort of like, it's bad, okay? You actually, it's probably easier to see them. Line goes this way and line goes that way. They're actually straighter and closer together. And actually, that's the wall of an airway, of a larger airway that's basically dilated, stuck, and it's all scarred. You know, so it really doesn't do very. It's not a very good thing. It's probably all filled with all kinds of garbage and mucus and stuff like that in that little area. You could probably see a couple more if you look a little closer. Maybe you could actually see something down in here that looks like a little airway that's open up in here. You can see that area right here between that, you know. So this is called bronchiectasis. The next term we have is called chronic bronchitis. Okay, and chronic bronchitis is part of that overall thing that we call COPD. COPD stands for chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. And again, by chronic, what I mean is it's something that's been occurring over a long period of time, okay? The most common cause of bronchitis, chronic bronchitis, is smoking. Smoking, as it paralyzes those cilia, allows all kinds of garbage to get trapped inside the airways, and it's just a great breeding ground for bacteria to sit down there and cause infection after infection after infection. And again, that infection, if it's repeated, then causes that bronchiectasis because of the destruction of the wall of the airway. Okay, and you can see down in here that when we get down in this situation, we get the airway that's you know, very small opening, and it's all full of mucus and stuff like that. If you know someone with chronic bronchitis, usually in the morning they have a tremendous cough, a lot of cough, and a lot of that cough comes up with that foul-smelling, really ugly-looking sputum, green, brown, tan, yellow, blood-tinged, gray, you know, you name it, and it just comes up there because what happens is all that stuff at night sits in those airways and fills the airways. Then they get up, and then they're so full of this gunk that they have to try to cough it up. Okay, and that's a problem that we see. And you can see that the chronic bronchitis is actually one of three things that we have what's called chronic obstructive pulmonary disease. The other one that we'll talk about is emphysema. Emphysema is actually a lung destructive thing. Those alveoli, they lose their form and they become large air bubbles inside the lungs, which actually do nothing. And then we put asthma in there. Now, asthma is not the responsibility of smoking or the response to smoking, where emphysema, definitely, chronic bronchitis, definitely, not asthma. Asthma is something, again, either allergy, cold, exercise, things like that, and various toxic inhalants could cause asthma, but chronic bronchitis is definitely part of that COPD problem, okay? And here's the problem. Both with emphysema and chronic bronchitis, guess what the treatment is? Close your eyes. What do you see? Nothing. You can't make it better. You know, once it's there, it's there. The tissue is destroyed. There's no going back unless you get a new lung, you know. There's no going back. Once the tissue is destroyed, it's going to be destroyed. You know, I've heard people say, oh yeah, in a couple of years, if you stop smoking, that everything goes back. Guess what? Not everything goes back. You know, there's going to be some damage, and the damage doesn't repair itself in the lungs very well. Okay, so the good idea is just don't smoke. You know, and you don't have these problems down the road. Again, I would say everybody with chronic bronchitis is a smoker, you know, and they've destroyed their lungs, and guess what? You know, you have to learn to live with it, okay? So that's chronic bronchitis. Last thing we have here is cystic fibrosis. Now, this is a sad portion right now. And the reason why cystic fibrosis is a genetic disorder, okay? And basically, if we look over here, okay, this thing right here that we see, this is chromosome 7, and there's a certain area right here on chromosome 7, on the long arm of chromosome 7, in this region, in this little band right there. And what happens is there's an abnormality in the genetic code at that gene right there, okay? And what it does, it affects somebody's ability to handle salt. Say salt? Yeah. What happens is in cystic fibrosis, the thing that occurs with cystic fibrosis is um, uh, normally we have secretions that keep things moist and normal amount that lubricates. People with cystic fibrosis, because of the problem with salt, they have a lot of thick, like molasses type secretions that develops in the lungs as well as in the gastrointestinal tract. Okay, now this would be the pancreas, and this would be the first portion of the small intestine. And here's a duct that's coming from the gallbladder as well from the pancreas that goes in there. What happens, these secretions become so thick that they block everything. And when they block the lungs, they'll block the small airways, large airways, and stuff like that. And it's something these people didn't ask for. It was a genetic type of a problem. And in the past, the life expectancy for somebody with cystic fibrosis was probably early 20s. Okay, usually much more commonly occurred in blonde-haired, blue-eyed people. Okay, for some reason, probably because the blonde-haired, blue-eyed gene is probably somewhere very close to that gene for the cystic fibrosis. Actually, it's an abnormality of that gene that causes the cystic fibrosis. Nowadays, they're actually coming up with newer treatments. In fact, it was probably just a matter of a few months ago, I just saw something about some other therapeutic trials that are very promising in regards to finding people to try to help them with cystic fibrosis to have significantly longer lifespans. There was also a period of time where people with cystic fibrosis, it became a little bit of a moral issue when their lungs were so trashed because their lungs get so blocked. They have lung infection after lung infection after lung infection, which destroys their lungs, just like we see in chronic bronchitis. But again, not because they did something to themselves that did it. It's just something that genetically inherited. But they were some of these people were undergoing lung transplants. The problem is even though they undergo lung transplants, it doesn't change the gene. So the gene is still there. So they still continue to produce abnormal mucus, a thick molasses-like mucus that blocks these airways, it blocks various ducts in the GI tract that cause problem after problem. Again, nowadays they're coming. They have some therapeutic trials that are showing some decent promise in regards to people with cystic fibrosis. But it is still a devastating thing, when you have something. It requires sometimes people they will have a genetic counseling just to try to counsel as to whether people should have children if they have this gene for cystic fibrosis. But that's cystic fibrosis. A couple of the lung disorders we have to talk about. Okay, now our next one is called atelectasis. Now A means without, telo means complete, ectasis means dilation. And what happens is if there's an area of my lung that I'm not using, these little alveoli, those little air sacs, I'm going to put my picture back up here, those little air sacs start to squish down. Just like if I take a sponge and squish a sponge down, I still have the same sponge, but squished down. Why? Because all those little air bubbles in the sponge are being squeezed, all the air is being squeezed out of them. And the same thing happens in atelectasis. The lung will actually squish down to a point where what will happen is that, it actually pulls the heart and everything over towards the one side. Okay, and as a result, that becomes a significant problem with atelectasis. Okay, people when they like after surgery and they don't take deep breaths, they sometimes get atelectasis. Emphysema. Emphysema is a situation where we have. Let me see if. Oh, they're all coming up behind. Emphysema is a situation where we have, again, it's a chronic obstructive pulmonary disease where in the case of emphysema, the alveoli become destroyed. Okay, where we have a destruction of the airways in chronic bronchitis, we have a destruction of the alveoli in emphysema, and as a result, instead of having small little air sacs where we have gas exchange, now all of a sudden I have these larger blebs or larger bubbles. Okay, and guess what they do? Again, nothing. So as a result, doesn't help a whole lot. Okay, so basically that's what we see with emphysema. Again, once the lung is gone, it's gone. There's no coming back. Okay, lung cancer. Lung cancer used to be thought to be a male-dominant disease, but we're seeing it more and more in females. And the American Cancer Society had proven a long time ago that the most common cause of lung cancer is probably still going to be smoking. Okay, without there was a direct correlation between the two. Now, lung cancer could either be what's called primary or secondary. Primary means it starts in the lung. It could be secondary, which means it started somewhere else and spread to the lung. Okay, so that's that. Depending upon the type of cancer there is, the life expectancy is exceptionally variable from one type of cancer to another cancer. Pneumoconiosis. Conio means dust. Pneumoconiosis is basically a destruction of the lung, basically by dust that's in the air. Okay, which could be coal dust, which could be silica dust like sand and stuff like that, things that you inhale. And what happens, it lines the lungs, and as a result, it does cause a significant problem. It causes a small little, sometimes little tumors that will form inside the lung, which are non-malignant, or they're a better way to say it would be benign type tumors that might be inside there, or it's sometimes just because it's dust and it goes all over the place. It involves the entire lung. People with a black lung, they frequently have, the whole lung looks black when they take it out. Okay, so that's pneumoconiosis. It's an inflammation and a destruction of the lung by inhaling dust particles. People who are on farms and they work with organic fertilizers, the organic fertilizers will also get in the air. If you ever look inside of a barn, you'll see, if the sun's coming through those little holes in the barn, you'll actually see all this little dust flying in there, and people are breathing this stuff in all the time. And as a result, that causes a problem. That's still pneumoconiosis. Pneumonia, pneumonitis, is just an infection of the lung. It could be either virus or it could be bacterial. 6 of one, half a dozen of the other, and it basically is a significant problem because you have to make the diagnosis early enough. A little antibiotic to be able to treat it if it's bacterial. Viral pneumonia, viruses you can't treat with an antibiotic. Why? Because viruses aren't alive. Antibiotics are meant to kill bacteria, and since viruses are not alive, viruses are just pieces of DNA or RNA that are encased in a protein coat, and that's all they are. So since they're not alive, the antibiotics have no effect on them. So pneumonia is either viral or bacterial. Okay, I'll talk a little bit more about that in a subsequent video. Okay, pulmonary abscess. A pulmonary abscess is just an infection of the lung where pus has collected. Okay, this happens sometimes. You'll have an infection, and then there'll just be a large pocket of pus, and that'd be called a pulmonary abscess. Pulmonary edema. It's funny because we think of it, pulmonary edema, and it should be a lung-related problem. It is, but it's actually more of a cardiovascular problem. Okay, if we remember back in the cardiovascular system, blood comes from the lung and goes to the left side of the heart. Okay, so blood's going from the right side of the heart to the lungs to pick up oxygen and goes to the left side of the heart. However, if I have left-sided heart failure, and we talked about that in the cardiovascular pathological conditions, if I have left-sided heart failure, the muscle of the left side of the heart can't pump blood out as fast as the blood's coming in. As a result, the blood starts to back up through the pulmonary veins into the lungs. Therefore, eventually the pressure of those little capillaries around the alveoli increases, and fluid starts to leak out of those capillaries, which it shouldn't. As the fluid leaks out of the capillaries, it starts to fill the little alveoli, and that's what we call pulmonary edema. Pulmonary edema. Okay, if it's not managed, if the heart failure is not managed, it can be fatal. I remember we'd have people come to the emergency room. They'd be pronounced. They'd have the doc go out and look at them and pronounce them. As soon as you open the mouth, there'd be all this pink, foamy, frothy material, and say, oh, they had heart failure, and they died of pulmonary edema. Because what happens is they almost like drown because the airways get filled of this pink, frothy, bubbly, foamy material. Simply because now, since the left heart can't pump out the blood that comes to it from the lungs, eventually it's going to back up. It's like if you have a creek and you throw a bunch of logs in the creek, eventually everything where the water's coming down is going to back up behind the logs, and it might flood land that's before it gets to the area where you actually block the creek. And the same thing happens here. If the left side of the heart doesn't pump out what comes to it, the blood will back up. Okay, and that causes the capillaries around the alveoli to have increased pressure in the vessels, and as a result, the fluid leaks out and fills these little alveoli, and people sort of like drown in their own fluids. Okay, pulmonary embolism, and that's what we're showing here on this image right here. And a pulmonary embolism is a moving particle of something through the vascular system. Okay. And we talked about this when we talked about the cardiovascular system. We talked about deep vein thrombosis, where they have a clot in one of the deep veins of the leg. The problem is, if the clot's there, the clot may break loose. If the clot breaks loose, it heads upwards, okay, and gets up through the inferior vena cava. Usually most of the clots are in the calf. Some of them are in the thigh, but most of them are in the calf. The clot breaks loose, it goes up from the leg, gets into the inferior vena cava, heads towards the right side of the heart, as I know. Gets into the right atrium is nice and big, there's nothing to stop it. Goes to that tricuspid valve, nothing to stop it, because nice big hole in the tricuspid valve. Gets into the right ventricle, guess what? Right ventricle is big, nothing to stop it. Goes to the pulmonary valve, out to the pulmonary arteries towards the lungs, nothing to stop it. But once it gets to the pulmonary arteries, at that point, when it gets into the lungs, the arteries get smaller and smaller and smaller and smaller. And now this clot that's down here, goes here back to the right side of the heart. Here's the right side of the heart, goes to the tricuspid valve. Here's the right ventricle over here, goes out through the pulmonary valve, goes out through here, the pulmonary artery goes to the lung here, and basically that clot gets stuck in some of the vessels of the lungs. And as a result, what happens is those areas where there's clot, there can't be any oxygen exchange. So someone's blood oxygen levels starts to go down and down and down and down. My dad died of a pulmonary embolism. Okay, so these things do happen sometimes. So that's the problem. We'll talk a little bit of a test that can be done. Pulmonary fibrosis. Pulmonary fibrosis is a situation where, and a lot of things could cause it. It could be chemicals that people inhale. It could be irritants that people inhale. All kinds of things. It could be certain illnesses that will cause this. And what it does, it just causes the lungs to become very scarred. Now, the lungs have to be able to expand pretty freely to be able to fill with air. However, if I take that lung and put a lot of scar in there, it doesn't stretch as well. And as a result, if it doesn't stretch as well, it can't fill with air as well. Therefore, it can't exchange gases in the alveoli as well. And as a result, guess what? Here we go back to our friend here, that blood oxygen levels that continue to go down and down and down. So there's lots of reasons why people have pulmonary fibrosis. And basically, that's fibrous and scarring. Scarring, okay? So the lungs become scarred and they get tight. The lungs get very tight, and that's what we see with pulmonary fibrosis. Okay? I'll show you I'll bring these other pictures up on another video and you can see. Oh, this right here, we can see this one. I'll actually take this video out and go over just these slides in another very short video, so you'll be able to see them. Somehow they came up behind everything else. And basically what we're seing here in this chest x-ray, here's the heart, sit right here. The heart's much bigger than it should be. The heart should only be about half the size. If I look from this side to this side, it should be only about 50%. Heart's much bigger. And see all these cloudy areas in here? That's the area of the alveoli being filled with fluid, with that pulmonary edema. So this is a pulmonary edema type of a chest x-ray that we see. I'll show you, I'll let it down here so you can actually see a little bit better. That's what we see with the pulmonary edema. The heart's too big. You can see a lot of this whole area here in the mediastinum is much wider. Okay, heart sitting way out here, heart sitting way out here. Heart should be like about here, about that way, about maybe about 50% of the size of the chest, size of the transverse diameter of the chest. But then the lung fields, these are called lung fields out here. They all look very blotchy and stuff. That's because they're all full of fluid. Okay, from the pulmonary edema. A couple of the lung conditions that we could talk about here. One is called sarcoidosis. Okay, and sarcoidosis is basically doesn't just involve the lung. People could get sarcoid. It involves the liver, it involves the skin, it involves the kidneys, it involves the heart and stuff like that. And what they do is they develop these tumors in here, and they're called granulomas. Okay, these are granulomas, and also lymph nodes that are in this area around the mediastinum. Okay. About a third of the people that have sarcoidosis, they get better on their own. Okay, about a third of the people continue to have problems, and about a third of the people get worse. What really causes it? I don't know. There could be a lot of different things. Nobody really knows a lot of times for sure. It's just there. They usually say they're having a problem. They do a chest X-ray. They find something that looks like this and say, oh, it's sarcoidosis. Okay, and they get these granulomas, these lumpy, bumpy things in the lungs, and basically they could treat them. What they do is they treat them with steroids. Okay, corticosteroids like cortisone. And basically that sometimes helps it, because what happens is there has to be some type of an immune response with this, and they really block the immune system. It's called immunosuppression, okay? And that's what we see with sarcoid. And again, sarcoid involves so many different organs. This is just showing what we see with sarcoid. Again, what you see is you see here's liver. It could be has skin manifestations and stuff like that. Lungs could involve the brain. The lymph nodes around the area of the trachea and stuff like that. Again, more skin lesions here, eye problems, heart problems, big spleen and stuff like that, and also may involve the joints. One thing is this picture is pretty accurate because the majority of the people with sarcoidosis are African American. Okay, so that's just another side thing that we see with that. It doesn't have to be, but it's not uncommon. Okay, let me get rid of these scratches here. Tuberculosis. Now, tuberculosis is caused by a mycobacterium, and it's a devil. Okay, it's a hard thing to really treat. Okay, the mycobacterium is covered with like this waxy coat that actually prevents a lot of antibiotics and stuff like that from getting into them. And what happens is tuberculosis, this mycobacterium, is spread by droplets. People cough, sneeze, and these droplets get spread in the air. Now, we were talking about social distancing, that's 6 feet. Usually the distance of a droplet, most droplets that are exuded by sneezing and coughing, because they have weight, they actually will go in a little bit of they actually will have a little parabola. They'll fall and they come to the ground because they have weight, and gravity will pull them down the ground. Usually about 6 to 8 feet that spray will go to. Well, in tuberculosis, we find that it's more common in communities that are tightly packed. We have a lot of people living in one small area. Very, very common to see tuberculosis in those individuals. Some third world countries where maybe you have ghetto areas where you have people living in shacks piled on top of 20 people in a room. And because now there's no social distancing, you're very close. What happens is if one person gets it, they spread it to a lot of other people. It's not gone in the United States. Okay. The problem, it causes these lesions. And this is this up here is also another granuloma. Okay. And what they do is they cavitate. The granuloma starts one size, gets bigger and bigger and bigger. As it gets bigger, it outgrows its blood supply, and the center becomes sort of hollow. Okay, and starts to fill with fluid. So you'll start to get some fluid that'll form on the inside of that. Sometimes you'll actually see, like in here, see how you see here's the opening right here, and you see almost like a little shelf on the bottom. I'll take that away so you can see. See how it's a little cloudier on the bottom, and that's just fluid that's on the bottom. People who are exposed to tuberculosis may not get active pulmonary tuberculosis. They get it, and they might have like an upper respiratory infection, like a cold or like a flu or something like that, and they get over it. And that's what the tuberculosis does. It sort of like goes into hiding. It sits there and says, I'm just going to wait until my time comes, and then I'll come out and have a party on my own. It just sits there for a while, and sits there for a while, and sits there for a while, and may never do anything for a person's entire lifetime. Or if there's a time when they're immunosuppressed, or if they're under a lot of stress or something like that, the mycobacterium says, might be a good time to take care of this. And what it does is then it creates materials that actually go out and break down the wall, because this granuloma is what the body does. When the bacteria, the mycobacterium gets in there, the body builds like a fibrous wall around it to sort of protect it. So like if you have a garden and you don't want the deer to get in there, what you do is you put a fence around it so the deer can't get inside. So what the body does, it creates a fence around that area of the mycobacterium. But what happens is the mycobacterium, when it wants to emerge, it secretes materials that actually will destroy the granuloma, and then now all of a sudden it goes over here, it goes over here, it goes over here, it goes over here, spreads all over the place. The upper lungs or the upper lobes are the more common areas for tuberculosis to be seen. When people get a TB skin test, okay, they go in, probably everybody has TB skin test. What they do is they put a little bit of protein material. It's called purified protein derivative, or PPD, okay? Purified protein P derivative, PPD. And they put this material in there, and they've taken some of the protein from the tuberculosis and put it in there. It's not going to kill you. It's not going to hurt you. But if you've been exposed to tuberculosis, that will cause that red big ring around that irritation, that inflammation, because your body's immune system says, yeah, that looks like tuberculosis to me, and let's go ahead and take care of it. It causes that inflammation. So that's what that TB test does. It shows if you've been exposed to TB before. And then when people get a positive TB test, they usually go in for a chest x-ray to see if there's those lesions in the lung, like we see, in here. And there's multiple lesions, Everywhere you see a little arrow, there's a lesion going on in there. The bad part about it is because it's a tough bug to kill. People, to try to treat it with antibiotics, it's usually a minimum of 2 and usually 3 antibiotics for anywhere from 4 to 6 months, if not longer. And they're finding some strains of TB that we have no antibiotics that will kill. It's a death sentence, particularly in certain areas of Africa, where there are certain strains of tuberculosis that, regardless of the antibiotic, it's not gonna, you're gonna die, okay, from it. In the past, before they knew about antibiotics with tuberculosis, they used to send them to sanitariums. That's what a sanitarium was, to stick them in a little hospital that was high in the mountains where the air was clean, and they thought that would make people better. Well, some people, they didn't make them any worse, but they didn't make them any better, but because again, sometimes the TB just sits there and does nothing for a long time. Other people continue to die. Okay, so anyway, that's a little about tuberculosis. And again, tuberculosis can also leave the lungs. Okay, it could be other places. It could involve the pleural, or the membrane that covers the lungs. It could go, it's called miliary TB sometimes, where it goes all over. It goes to the bones and the joints. It goes to the urogenital areas, down to the bladder and stuff like that. Goes into the lymph nodes. It causes enlarged lymph nodes in the neck. And it could even involve the central nervous system up in the area of the brain. Okay, so that's what we see. I remember when I was a resident, we did a surgery on this one guy, and he had his lung, or this a bone lesion. The bone was expanded. And what happened was, I had recommended to my attending physician that maybe we should get a culture of it, and we also got a TB culture. Sure enough, came back positive for TB. So I remember we all had to go get TB tested, and basically we were clear, didn't have anything like that. So that's tuberculosis. Mesothelioma. This is a horrible disease. Okay, and if you're sitting up at night studying for a midterm exam, at 2 o'clock in the morning, you might hear something. If you or your family has been exposed to asbestos, call our law offices, or whatever the case may be. What happens is asbestos is small filaments. Okay, small little microscopic filaments that get in the air. And when people are around asbestos, when they clean asbestos and stuff like that, and they breathe the filaments in, because they're so small, they go out to the periphery of the lung. And what they do is they cause a level of inflammation out in the periphery of the lung, out in this area, out the outside. And what happens is then it causes this area of inflammation then becomes a cancer called a mesothelioma. The life expectancy for mesothelioma is about 1 to 1.5 years. That's about it. And it's usually on both sides, because you breathe it on both sides. But that's a huge problem that people will get. Okay. They've also found, and this is a little bit spooky, they've also found that the family members of people with mesothelioma are also more likely to get mesothelioma. Their incidence of getting it is higher than someone who's not a family member. And the reason why is not genetic. Is because what happens is when they come home and they comb their hair or take their clothes off, they disseminate the asbestos particles in the air. Family members breathe them, and then they may too get mesothelioma. Not nearly as much if you're exposed to it, like on an occupational hazard. That's why a lot of times in buildings now that have asbestos used to be used as a insulation material. And what they find now is sometimes it's easier just to tear a whole building down than to go in and try to strip the building of asbestos and to make it safe. Okay, they just sort of rip the whole building down, take it and dispose it in a safe place where they could get rid of the asbestos. And people that are working with asbestos are always wearing respirators, so they're not inhaling that anymore. So, but they can still take it on their clothes. So usually have to clean a lot of times they'll shower or change their clothes before they even go home. Make sure they have hair coverings and stuff like that so that they don't take it home in their hair. But that's mesothelioma. Again, horrible cancer. Life expectancy about a year and a half. Pleural effusion. Pleural effusion is a situation, and let me get rid of myself here. Is what happens is if fluid develops between in that pleural cavity. We talked about our visceral pleura. So let's say this is the lung right here. Here's my visceral pleura, and then we have the parietal pleura. And normally that area between is called the pleural space. It's usually very small with a little bit of fluid. However, if the fluid builds up, we get what's called a pleural effusion. Effusion means a collection of fluid. And what you see here is, if you look here, here's the diaphragm. Well, see, it comes up like that. Now this is a little meniscus end right here. If you have a test tube and you put water in it, if you look at the water, it comes up the sides, and at the sides it comes up like this. And that little area at the side where it curves up is called a meniscus. So fluid is actually filling this area right here should be black and dark all the way down. It's called the costophrenic angle. And that should be nice and clear. That's still filled with fluid right there. That's a pleural effusion. They could stick a pleurocentesis. They could stick a needle in there and suck the fluid out. But the problem is it's going to come back unless they know what's actually causing the problem. You know, why it's really there. We talked about pleurisy and pleuritis before, okay, with the pleural friction rub a little bit. And basically that's where we have the inflammation of the pleura, and it causes that rub. And you can see the pleurisy right here. Yeah, Gramps says pleurisy and stuff like that, and that's the area where there's that irritation right there. So what happens is now the lungs start to rub. The visceral and the parietal pleura rub against each other with that inflammatory membrane, and as a result that causes pain and stuff like that. Pneumothorax. Now this is a pneumothorax, okay? And I just want to do something really quick. I just want you to look at this lung. And okay, so over here is the left side, and here's the right side. It's always a marker right there, even though we know that the heart usually points to the left over here. But there is something that's called situs inversus, where actually the heart points to the opposite side. Everything is backwards in people's bodies. Not very common, but there is. What can you tell me the difference is? Look at this lung here and compare that lung to this lung. This lung looks a little bit grayer. This lung looks blacker. Why? Because there's no lung here. The lung's totally collapsed, okay? When the lung collapses, okay, and I'll take my scratches away, you can see, you can actually see the lung right here, and where you actually see the lung is this little squiggly thing right here. The lung is totally collapsed. It's deflated. What's all this in there? Well, you see the ribs, but it's black because all that is the whole side of the chest is filled with air. Now, if you're watching Grey's Anatomy or any of those other crazy, soapy medical shows and stuff like that, there you'll see them, let's put it in a chest tube. So what they'll do is, let me get rid of me again, they'll take a tube and stick it through the chest wall between a rib, and then they stick it in here, and then they suck the air out. And as they suck the air out, it allows the lung to expand a little bit, expand more, until the lung gets totally expanded and it fills the chest cavity. And then at that point, they could probably pull the chest tube. Okay, but this could occur because of a puncture wound to the lung. This could occur sometimes if somebody has emphysema, and one of those little bubbles, which is, those bubbles, by the way, in emphysema are called blebs, B-L-E-B, bleb. If a bleb ruptures and all of a sudden the air leaks out of the lung, it's going to fill and then it causes the lung to collapse. Because what happens is, if I look at that visceral and parietal pleura, again with the fluid in there between, the visceral and parietal pleura, they're allowed to slide on each other, but they're actually against each other, because there's almost like a negative pressure in this pleural space. What happens is if I have opened that pleural space or put air in there, it decreases that pressure, and all of a sudden the lung will collapse. Okay, and that's called a pneumothorax. Okay, so it's not an uncommon type of a condition. It's very, very common. Sometimes it occurs spontaneously. There's a thing that's called a pectus excavatum. If you ever know some people, if you look at your sternum is usually flat. Some people it's not. Some people have a congenital deformity where the sternum is actually pointed inwards, comes into like a point, okay? And that's called a pectus excavatum. pectus excavatum, they're much more likely to have just a spontaneous pneumothorax. It just ruptures. The lung just ruptures and air gets in there and stuff like that, and they put a chest tube in or whatever the case may be, and they're fine. But bullet wounds, knife wounds, stab wounds, projectiles through the chest, all those things, they allow air to get in that area of that pleural space, which allows the lungs to collapse. Okay, it decreases that negative pressure, that suction or vacuum that's in there, and the lung will collapse. Couple of clinical procedures that we have here. Chest x-ray, we've already shown a bunch of chest x-rays so far. And basically it's using x-ray just to look. We can see a lot of different things. We can see the lung fields, infections and stuff like that. Computed tomography. Computed tomography is the same thing as an x-ray, but it's just taken in slices. So they can actually do an x-ray of the chest, but when they take it in slices, by taking in slices, boom, 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 slices, they're able to see little segments of the lung, and they can actually almost recreate almost like a three-dimensional picture, okay? And that's called a computed tomography or CT scan. Pulmonary angiography or arteriography is where they actually could go ahead and inject dye into the pulmonary arteries to see where the blood is going. When people have a pulmonary embolism, when they put the dye in, it can't get past the clot. So as a result, they lose that seeing the dye in the vascular tree after that area of the clot, and that's just called pulmonary angiography. Magnetic resonance imaging or MRI looks like an X-ray, but it's not. Okay, magnetic resonance imaging basically is looking at hydrogen atoms in the body as how they respond when they're put in a magnetic field and they're given an energy source. And what happens is they start to wobble. They absorb energy. Then when you turn off this energy source, they release energy. You measure the amount of energy that's released, and it gives you an image. So they could use MRI to look at the lungs, at the heart, and stuff like that. And you're able to see some soft tissues better than you can otherwise on X-ray. Okay. PET scan. You've probably heard of PET scan. PET stands for positron emission tomography. PET scan. And what a PET scan is they take glucose. Okay. And they know glucose is used as a fuel. They tag glucose to a radionucleotide or a radioactive material and inject it. When they do that, what happens is that the areas that are metabolically more active will take more glucose because they need more energy, because they need feed me, Seymour, I need more energy. They need more energy. And as a result, because of that, these areas will light up on this scan. They do a CAT scan, but is able to see the areas where the radioactively tagged glucose goes to, and those areas light up. So PET scans become really helpful in looking at things like tumors and stuff like that, because in a lot of cancers, what will happen is the metabolic rate of those cells increases. They're making more cells. Cells are dividing faster in most cancers than we find normally in the body. And as a result, what happens, they need more energy. That draws more of that radioactively tagged glucose, therefore those areas light up, and that's called a PET scan. Okay, I'll show you that in a minute. And then we have a last thing, it's called a VQ scan or ventilation perfusion scan. What they do to a ventilation perfusion scan is they do an angiogram, okay, on one half, but then they also have you inhale a radioactive material, and you can see where the air goes. Now, where's the air going to go when I inhale it? In the airways. Where's the dye going to go when you put it in the vessels? In the vessels. What they're looking for is they're looking for a pulmonary embolism. If in a pulmonary embolism, what they'll find is the air is the lungs are fully full of air, but there's an area where the blood supply is not going to because it's blocked by a clot. And that's what's called a VQ scan or a ventilation perfusion scan. Now, this is just a typical chest x-ray, okay? Let me get rid of my picture here. Just a typical chest x-ray. You can see the heart right here. Here's the aorta right here. These are the areas, the vessels as well as the bronchi coming off. Here's the diaphragm on this side, the diaphragm on this side. This is actually the stomach bubble in there. Here's a clavicle here. Here's the arm here. You know, here's the trachea. You actually see where it divides. There's a carina right here. It's right where that, right there. There's goes that way to the bronchus that way. And that's what we see. That's a typical chest x-ray. Now, this right here is basically a CT scan, okay? And what if it's on an axial plane or transverse plane? And you could probably figure that one out. That's the one on the top right here. And this one right here is on the frontal plane. So basically, it's hard to see right here, but they're actually taking slices. So when you look at it, you look at one slice and you look at the next slice, you look at the next slice, and it gives you almost like a three-dimensional representation of what's going on when you look at all the slices, one slice after another, after another, after another, after another. This is a pulmonary angiogram. okay, like we talked about before. And what they've done is here's the pulmonary artery. If you look right here, there's pulmonary artery coming here, pulmonary artery coming right here. Heart's going to be down in here, okay? And basically they're looking at this, all you see here, these little trees, those are all the vessels that are going to the lungs. And then, so they're doing a pulmonary angiogram or angiography and, arteriography, just to, and this is all dye. It's white because it's all dye that's injected inside the vessels, okay? So that's what we see with that. This right here is an MRI, of the chest. Again, it does show some things. We actually look here and we can see a couple cool things here. The vertebrae right here. Spinal cord is going to be sitting right in there. Okay. Here's the heart. Okay. Here's one of the chambers of the heart. There's a little clear space right behind the sternum. You can't see much of the lungs. Here's part of the aorta right there. Here's some other vessels that are right here. And then we can see this is the diaphragm is right here. This is the abdominal organ sitting down in there. This is the back right here. This is the abdomen. It's the chest right here. So that's what we see right there. Okay. So that's just a typical MRI. And you can see some things, and it's sort of limited as to what you actually could use an MRI for. Now this is that PET scan like we talked about. Okay. And what happens, it's doing a CT scan, but what happens is with that radioactively tagged glucose, you can see certain areas light up. If I'm looking right there, that area lights up. That area lights up. That area. Both of the kidneys. That's a kidney right there. That's a kidney. That's the heart. Okay. So basically, but you should see the kidneys. Why? Because the glucose is being eliminated through the kidneys, through the urine. Actually, in a little bit, if you took another image later on, down here, you'd see it light up, and that'd be the bladder, because all the dye is the radioactively tagged glucose, and the radioactive material gets absorbed by the kidneys, gets pushed down the tubes that go to the kidneys, the ureters, and fills the bladder, and eventually will eliminate it out. What they're actually looking at as significant here are these right there. Those are little lymph nodes. They're in the neck, which shouldn't be there. Those are a little more active, probably either from a lymphoma or leukemia or something like that would be there, and that's called a PET scan, positron emission tomography. And then we have, this is called a VQ scan, or that ventilation perfusion scan, okay? And with this ventilation perfusion scan, here's the perfusion. If you look at the top, up at the top, okay? They're looking at, this is reflective of the blood flow, okay? The blood flow is going there. This is the ventilation, okay? And what they do is they match, are the lungs being fully filled with air, which they appear to be, but is there an area, like this area right here, is a little bit devoid of circulation? It might be reflective of something like a pulmonary embolism, okay? And so I use a ventilation perfusion scan, or VQ scan, for pulmonary embolism. A couple other words that we have: bronchoscopy. Bronchoscopy is basically looking inside. They could take a fiber optic tube, and look down inside the bronchi, just to see if there's any type of tumor or something like that might be there. And this is what bronchoscopy would look like. Now, what happens? They're looking down. You can actually see the trachea. See the rings of the trachea, like we talked about. There's a tumor sitting right there. What we're seeing right here, that's the carina. So there's a bronchus going one way, bronchus going the other way. Okay, and they could continue on going down and get further and further and further and further and further and further on down. Okay, so that's what we see. So, but you can actually see the tumor sitting right there. You can actually see some lesions right there as well. So that's called bronchoscopy. Endotracheal intubation is basically this process right here, where it's a matter of putting a tube in the airway. So what they do is they use this thing right here. It's called a laryngoscope. It has a little blade, and they just take it and they tuck it either behind the tongue. Here would be the epiglottis right there, and they pull the epiglottis forward, open it up, and then pass the tube. So here's the tip of the laryngoscope, and they put the endotracheal tube down there. Now right here you can see there's a little cuff. And the little cuff, once they get it down there, they take this little thing and put air in it. They take a syringe, put air in there, it blows up the balloon right here, so it stays in the trachea, so it doesn't move around. Okay, and then they hook this up right here. This end up right to a ventilator. So that's called an endotracheal intubation. Okay, so and when people have a lot of times, general surgery, they always put a tube in you and stuff like that. You see people now with COVID, when they put them on a ventilator, they put a tube in them, something like that. Okay, and they're going to also do laryngoscopy is something else. Okay, they could also use the laryngoscope for laryngoscopy, but this is the way that they used to do it. I tried to do this when I was a student a long time ago. You take a mirror and you stick a mirror right on the soft palate, and you have them say the Their soft palate rises, their tongue goes down a little bit, and then you shine a light this way. It comes off the mirror and bounces down that way, and you're able to see the vocal cords. Nowadays, much simpler. Just use a fiber optic tube, passes up the nose. When it gets up the nose, goes down the back of the throat, and guess what? You have a little camera right in the end right there, and you take a nice little view of the larynx right down there, and that's just called laryngoscopy. Okay, and this is what you'd see with the laryngoscopy. Okay, when you're looking at that, you can actually see some things we talked about before. Here's the epiglottis right here. Here's the epiglottis right here, and then here's the vocal cords. And if you look right between there, that would be going into the trachea right there. You can see the trachea. They're going inside the trachea right there. Okay, so that's just called laryngoscopy. Lung biopsy. This is just taking a lung biopsy. They usually use a needle. Okay, and what they do is they just take the needle in. The needle has a core, and what they do is they pull up. They create some suction. It sucks a piece of tissue up in that tube, and then they pull it out. Okay, and that they just, and a biopsy is basically taking out a piece of tissue just to look at it underneath the microscope to see if there's anything abnormal with it. This is called mediastinoscopy, and mediastinoscopy is basically now they just make a little slit up here at the top, of the chest, and then just go down with a scope and look inside. And they can actually see inside everything. Look at around where the great vessels are, around the side of the trachea, the esophagus, and stuff like that. That way they don't have to open the whole chest. They just go through a small little tube that they could look in, a little visual thing. Actually, most of these are set up to a camera, so they could look on a big screen TV, on the outside. So that's just called mediastinoscopy. Okay, pulmonary function tests. You may have had these before, where what happens is you breathe into this thing, and they measure your pulmonary function capacities. There's a number of different capacities, and we don't have the time to talk about it. Vital capacity, expiratory reserve, blah blah blah, a bunch of different things. They're just measuring how your lungs are functioning, what the capacity of your lungs are, and they could determine by what they see and what your capacities are in regards to things such as pulmonary fibrosis, another type, chronic obstructive pulmonary disease, and stuff like that that may be causing a problem. Okay, thoraco or pleural centesis is basically sticking a needle, and into that pleural space with the fluid. And if we look here, here's a lung right here. Here's the chest wall out here. Here's a rib. They go in right above a rib. They don't go below because the nerve and blood vessels are sitting right here. So they go right above the rib. They go inside there. This fluid would be fluid. They suck it out, and they can evaluate the fluid for whatever they need to look at it for. This would be a thoracotomy. Okay, and this is a surgical thoracotomy. What they've done is they've just opened the chest wall. Now they're looking inside, and actually what you're actually seeing down there between the ribs is the lung. So we're able to do that and basically look inside, stuff like that. That's just thoracotomy, just means thoraco means thorax or chest. Otomy means cut into something. Okay. They could also do thoracoscopy, where they could actually go through a small hole with that same fiber optic tube and look inside the chest. That's called thoracoscopy. Tracheostomy. Basically, what they do is they go below the vocal cords. The vocal cords going to be up here. They go make a hole below the vocal cords and then put a tube in. And so therefore they could breathe through this tube. It's for like a laryngeal cancers or other things like that where people can't breathe through their mouth. Okay. There's something back of the oral airway or the back of the larynx, and basically they put this tube in for, and they leave it in. They could actually, so they could breathe through that area of the tube. You've probably seen somebody with a tracheostomy tube in at some point. Tuberculin cyst is basically, like we talked about before, is taking a little bit of that PPD, purified protein derivative, some of the protein from TB that's been denatured or sort of destroyed, but still protein, and then inject it, make a little bubble, underneath the skin. And then what happens is if that area is positive, then it causes this big reddish welt that occurs there. The body says, that should be there. That's TB. Let's kill it. They go there and they send all their invaders, or they send all their natural defenses, their antibodies there to try to kill it. Okay, and that's why it turns red and puffy and stuff like that. That means you've been exposed to TB, and the TB is somewhere in your body. Okay, and that's the tuberculin test. tube thoracostomy, okay, and basically that's what we were talking about before with that chest tube. And basically what they've done is they've actually, this is a person who they surgically, they scrub it, you know, and then surgically, it's not an operating, they do this in emergency room and stuff like that. They just make a little slit in the chest, just above a rib, lower rib, and then start and go almost all the way down to the pleura, and then they take this tube, okay, and then they just take that tube and hold it between a big clamp and punch it right on through. Once they get it in there, they put some sutures around the outside just to hold it, and then they attach that tube to a suction out here and sucks out air, or sometimes they also have a tube in there to suck out blood. There's a lot of blood inside the chest. Okay, and that's just called tube thoracostomy or chest tube. Now, we don't have a whole lot of time for this. I'm just going to tell you a couple of these that I think are really important. Okay, first of all, ABGs, arterial blood gases. I think that's a really important one, arterial blood gas. AFB stands for acid-fast bacteria, and that means TB. Okay. ARDS, acute respiratory distress syndrome. I think that's something that you might want to think about. CO2, you know, is carbon dioxide. COPD, chronic obstructive pulmonary disease. CPR, cardiopulmonary resuscitation. This one right here, CNS. CNS stands for culture and sensitivity, which means that what they do is if somebody has an infection, they take a little bit of pus, and when they take the pus, they put it on a plate and grow it to see what the bacteria is that's causing the infection. And then they also take that plate and have antibiotic discs on it. They place these little discs all over the place. And what happens is if the bacteria grows up and over the disc, it means don't use that antibiotic. But if the bacteria won't grow over and it leaves a big clear space around it, that means that's an antibiotic that's good. CXR, chest X-ray, arterial blood gases, acid-fast bacillus, acute respiratory distress syndrome. Don't worry about that one a whole lot. Carbon dioxide we know. COPD, chronic obstructive pulmonary disease, definitely know that one. Continuous positive airway pressure, that's something if you're going to respiratory therapy, that's good. Cardiopulmonary resuscitation, culture and sensitivity, like I said, like I just explained. CTA, cleared auscultation. You know what, I've never used that, you know, but I suppose it's okay. CXR, we know is chest X-ray. A couple more abbreviations that we talk about here. DOE. DOE stands for dyspnea on exertion. What that means is dyspnea means bad, difficult. PNEA, breathing. When they have difficulty breathing when they exert themselves, when they're walking. DPT, diphtheria, pertussis, tetanus. We talked about that before as that vaccination. You know, diphtheria. We talked about that. Pertussis is whooping cough, and everybody knows tetanus. You know, ERV, expiratory reserve volume. Again, if you go into respiratory therapy, that's another one. Same thing with FEV1, forced expiratory volume in 1 second. You know, FVC, forced vital capacity. These are all respiratory. You know, respiratory tech type terms, okay, that you might want to know. Handheld nebulizer, also with that. HCO3 means bicarbonate, okay. Bicarbonate is a buffer for acid. ICU we know is intensive care unit, piece of cake, okay. This is another respiratory thing. IRV, inspiratory reserve volume. I don't think I'd make much care about that. LUL, left lower lobe, left upper lobe, piece of cake. We talked about that one before. This is also for respiratory therapy, so I wouldn't worry too much about that, okay? Same thing with nasal cannula. NIV, non-invasive ventilation, again, for respiratory therapy. And NSCLC, non-small cell lung cancer. They look at small cell lung cancer and non-small cell lung cancer. And that's how they sometimes determine what the survival rate's going to be by what type of cell it is. O2, you should know. Oxygen, that's a given, okay? Obstructive sleep apnea, that's basically sleep apnea. PaCO2 is carbon dioxide partial pressure. This is what they measure. When they measure your blood gases, they actually look at the partial pressure of those gases. And PaO2 would be partial pressure of oxygen. Partial pressure means almost like the concentration of it, okay? So if they say PaO2 of 97, that's about 97%. PCP, pneumocystis pneumonia. Pneumocystis pneumonia, let me just mention one thing about it. What they find is pneumocystis is basically a bacteria that lives in almost all of our lungs. Here's the problem. The other bacteria take care of it. The other bacteria sort of like say, nope, you know, stay in your own corner, don't come out. The problem is when our immune system gets really damaged and destroyed and trashed, okay, the pneumocystis pneumonia can emerge. What's the situation that usually is? AIDS. When somebody has HIV, it means that they're positive for the human immunodeficiency virus. When they finally start to show symptoms, that's what they call AIDS. Their AIDS in the AIDS, there's a certain cell which is called a CD4 cell in my immune system that doesn't work. So therefore, people with AIDS, okay, what happens is their immune system is trash. They can't fight infections. This pneumocystis carinii bacteria goes crazy, goes overboard, nothing's to stop it, and a lot of times people with AIDS die of pneumocystis pneumonia. Okay, PE, pulmonary embolism. That's one you should know. That's a very common thing. That's a clot that goes to the lung. PEP, positive expiratory pressure. Again, that's a respiratory therapy type of a term. Couple more. PEEP. That's another one. Respiratory therapy. PFTs. I think I would know that. Pulmonary function tests. You know, that's what they do want to test your functional breathing capacity. PND is one that's probably also cardiovascular. It's called paroxysmal nocturnal dyspnea. And what happens, paroxysmal means comes in spasms or bouts. Nocturnal means at night, and shortness. What happens is when people have a heart failure, when they're up, their ankles start to swell. Okay, during the day when they're up, because the heart's not pumping things back, everything backs up in the systemic circulation, their ankles swell. When they lie down at night, they don't have to worry about gravity. All the fluid that's built up in their ankles gets back into the circulatory system, overloads the circulatory system, overloads the lungs with vascular flow, and they get short of breath at night. So it's more of a cardiovascular related thing than actually a pulmonary thing, okay? But it's a pulmonary manifestation. PPD, purified protein derivative, like we talked about, that's that TB test we talked about before. RDS, respiratory distress syndrome, like the ARDS. RLL, RUL, right lower lobe, right upper lobe. RSV, respiratory syncytial virus. It's a virus that does cause a significant lung infection. I do know one child that died from RSV, and it's a virus that does cause a pulmonary infection. So right upper lobe, okay, and we have a right middle lobe too. So right ML, okay. So anyway, RV, residual volume, that's a pulmonary function test, okay. SCLC, small lung cell cancer, again, the non-small and the small lung cell cancer that we talked about before, and synchronized intermittent mandatory ventilation, again, that's more of a pulmonary therapy, respiratory therapy thing. SOB, shortness of breath, definitely know that one. That's a big one. Or your instructor, SOB. TB, we know TB, tuberculosis, not a problem, okay. TBN, NA, transbronchial needle aspiration, I don't think I'd care too much about that. TLC, total lung capacity, that's not give them a little TLC, but this is actually total lung capacity. URI, that's definitely one you should know. Upper respiratory infection, like people have a laryngeal tracheal bronchitis and stuff like that that involves the upper respiratory tract. URI, okay. VT, tidal volume. VAP, I don't think ventilatory assisted pneumonia. VATS, again, video assisted thoracic surgery. And they do a lot more of that, looking through a tube and a scope, vital capacity, what your lung capacity is. And VQ scan, we talked about, that's for pulmonary embolism. And that pretty much gets me to the end. We've actually gone a little bit longer on this video, and I will show some of those x-rays and those ones that we did miss a little bit later. I'll put that a little bit later on. You still get what we talked about, but hopefully this allowed you to think of some of the words that we had when we did vocabulary terms and put those into real use. And maybe learn a little bit more about some of the medical conditions that really involve the pulmonary system, which I think is going to help you in the end. So again, if you have any questions, you can always give me a call, or but don't give me a call. Just email me. That's better, because I'm not at school, so it's hard sometimes for me to get my phone at school, and you don't know my cell phone. So basically, just email me. I'll be more than happy if you want to set up a one-on-one with WebEx. That's perfectly fine as well. But hopefully, this was not just something where you're able to hear some of these words and talk about some of these words, but also something that maybe give you some more information about some of the things you always wondered about. So anyway, in the meantime, be safe, be smart, be healthy, and we'll talk to you.